This week, we are going to be looking at culture as a variable in practice. I want you to be able to assess your own biases in healthcare and how these affect the care you give to patients. I want us to look at certain groups and see who gets inequitable care in healthcare and how this affects their overall health outcomes. This chapter will review the relationship between race, ethnicity, poverty, and health disparities. The goal of this chapter is to take personal inventory. What is your level of cultural and linguistic proficiency in caring for culturally diverse populations? Does your current practice meet the legal and regulatory requirements established to deliver culturally competent care? Can you identify resources in your community that you and your professional colleagues can utilize to promote culturally proficient care in your practice setting? The ultimate hope is that you can integrate information from this chapter into your clinical practice. I want to share with you a couple of resources that I used in preparation for this lecture. One of them is on the Georgetown site. It is found on the NCCC web. It's http://nccc.georgetown.edu. And what this one is called is a tool that is named Cultural and Linguistic Competence Health Practitioner Assessment. One of the main reasons that I utilize this tool is this tool helped me evaluate what areas as a provider that I need to work on. What are those areas that I'm biasing that I don't realize? These are implicit biases. They're biases we have that the first problem is we don't see them in ourselves, and so we're not able to tackle them. Another good tool that I was able to use was Harvard's implicit bias tool. And this tool lets you go through areas that you think you might have a bias in and take some quizzes to identify what type of bias you have. The first step whenever you think of behavior change is just recognizing it. And once you recognize these areas of weakness, then changing your behavior behind them and working on providing more equitable care so that we can have better patient outcomes across more diverse groups. Sometimes if you're realizing one group you're struggling with, I find sometimes just getting a better understanding of their background, doing some research into their culture, and by understanding them more, I find that some of those biases can decrease. Every 10 years, the U.S. Department of Health and Human Services produces a comprehensive assessment of the health of Americans and sets goals and objectives for improving the health of the U.S. The Healthy People 2010 goals are to eliminate disparities in access to care, with equity as a key goal, and attain high-quality, long lives free of preventable disease, disability, injury, and premature death. In 2020, two other goals were added. One, to create social and physical environments that promote good health for all. And second, to promote quality of life, health development, and healthy behaviors across all life stages. The Pew Research Center found that 29% of growth in the U.S. population since the year 2000 was from immigration, with the majority from Latin American or South or East Asia, which is a change from the past, which was from European descents. The 5 states with the largest percentage of immigrant children under 18 living with their parents relative to the state's total number of children were California, Nevada, New Jersey, New York, and Texas. By 2030, 1 in 5 Americans will be 65 or older. You may have heard of this reference to as the gray wave. By 2044, more than half of the population of the United States will be members of a minority group. By 2051, the population of the United States is expected to reach 400 million people. These nationwide statistics do not capture the complexity of delivering culturally competent care. The data on racial origin are associated with different health statuses and disease, condition-specific morbidity and mortality, and socioeconomic status. By 2016, AHRQ, the overall percentage of people unable to get or delayed in getting needed medical care, dental care, or prescription medicine in a 12-month period was 11.7%. People in poor or near poor households were more likely to be uninsured than households that are not poor. In the years from 2010 to the first half of 2015, Blacks and Hispanics were less likely than whites to have a usual place to go for medical care. For each group, the disparity in quality of care was also similar to the disparities in access to care. What this means is not only did these groups have a hard time accessing care, but they did not receive the same quality and care as their white counterparts. In my own practice as a midwife, I can see the disparity in healthcare across different groups. The 2019 CDC Morbidity and Mortality Weekly Report notes that Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. When I think of how to solve this problem, I envision changes on multiple levels. There needs to be implementation of standardized protocols and quality improvement initiatives, especially among facilities that serve disproportionately affected communities. Practices need to identify implicit bias in healthcare that would likely improve patient-provider interactions, health communication, and health outcomes. Implicit racial bias refers to attitudes or stereotypes that affect our understanding, actions, and decisions that we are not conscious of. To identify our implicit biases necessitates a hard look at our beliefs and how these beliefs shape our interactions with our patients and those around us. One tool to help evaluate implicit bias is implicit association test. This test reviews several different areas of bias and lets you see your level of automatic bias. And again, this is found on Harvard's website. I will send a link out to that in this week's announcements. In 1997, President Clinton appointed a Presidential Advisory Commission on Consumer Protection and Quality in the healthcare industry, better known as AHRQ. This organization has played a key role in identifying health disparities in the current system and making recommendations to reduce these disparities and improve quality of healthcare for all Americans. In 2010, President Obama signed into law the Patient Protection and Affordable Care Act, which was passed on March 23, 2010, which mandated the development of a national quality strategy. The NQS established 3 comprehensive goals: better care, healthy people, healthy communities, and affordable care. Other organizations that help establish standards of care to reduce equity discrepancies in minorities and different groups is the Institute of Medicine, National Quality Strategy, and Office of Minority Health. Let's do a quick knowledge check. Which of the following statements about disparities in healthcare is true? People in middle-class households are more likely to be uninsured than those in poor households. The percentage of people between 18 and 29 who don't have insurance is decreasing. The number of adults with insurance who don't get urgent care as soon as they want is decreasing, and racial disparities in insurance coverage are increasing. So the answer to this question is B. The percentage of people between 18 and 29 who don't have insurance is decreasing. So from January 2010 to September 2015, the percentage of people under age 65 who were uninsured at the time of the interview decreased from 17.5% to 10.8%. Adults between ages 18 and 29 experienced the largest declines. When you think about this, we just talked about one of the reasons that this occurred. It's the Affordable Care Act. A couple statutes in this changed. For example, previously, adults were not able to be insured after they moved out of the house, but now adults under the age of 26 are still able to be under their parents' insurance. This is an example of a way that expands care. Another way is there's an expansion to the Medicaid, which would get more adults coverage. And then another coverage is there's an exchange system that has government supplemented insurance that would also help those who can't get insurance through their work to be able to still get insurance. So this is a great example of how legislation can increase access to care by helping more people have insurance, because our system is a system that requires insurance for good access. One thing that I want at this point to point out to you is to think of the role of advanced practice nurses on the future of healthcare. The use of advanced practice nurses can improve access to care and close some of this disparity in healthcare by providing a usual place for medical care for those who don't have good access or do not have a current usual place for medical care. Advanced practice nurses can also work to improve the quality of care to these different groups by viewing their own implicit biases and working towards providing evidence-based care. A good example of this is you think of some areas that might be rural medicine, or maybe some areas that just actually don't have good access to medical services. Having advanced practice nurses is a way to expand services to these areas. So we're going to talk a little bit more about the Affordable Care Act. As a provider, I actually practiced medicine prior to this passing. When it first passed, there was a huge change in my patient population. All of a sudden, I had all these patients who had never had access to services. Many patients who hadn't seen a doctor in years, many patients who had many comorbidities, many complicated patients, diabetes, metabolic syndrome, elevated blood pressures, who hadn't had any of their cancer screenings, any of their cholesterols, no diabetes testing, breast lumps. I almost felt overwhelmed when the Affordable Care Act first passed and patients started getting on the exchange, because what I saw as a clinician was patients who had just not access to healthcare system, and they were sicker than I think anybody really realized our population was. Why I kind of bring this up is there was a couple of things with Affordable Care Act that people didn't realize, and one of it was how expensive it was going to be. These patients came and they needed multiple services. They needed help accessing these services. Oftentimes my visit would just start with getting their general cancer screenings done, their general laboratories done, and usually almost 2 to 3 referrals for specialists. And so where we had a healthcare system that wasn't focused on preventative services and only gave services when people were sick, expanding coverage was costly. It was a good thing, but as a provider, I can tell you the before and the after of the Affordable Care Act was huge. I saw a huge difference on who could access care, and these patients had gone a long time without access. Just something to think about when you think about the costs associated with the Affordable Care Act. The Tax Cuts and Jobs Act of 2017 reduced, so initially with the individual mandate for the Affordable Care Act, there was an individual mandate to this program that basically required everybody to get insurance or to pay a penalty. And this, of course, increased buy-in, because if you're going to pay a penalty cost, then you might as well just get the insurance. And again, that Affordable Care Act expanded the Medicaid, so giving more access to more patients. Also, it changed the age where people could be covered under their parents, and also provided an exchange that was subsidized by the federal government. That was kind of a system based on how much income you made to how much subsidizing was awarded. The Tax Cuts and Jobs Act of 2017 reduced the finer tax for violating the individual mandate to 0, and this started in 2019. So this actually was one way of de-incentivizing patients from getting health insurance, because without a penalty, some people would opt to not have health insurance. A couple other things when you think about the Affordable Care Act is, prior to the Affordable Care Act, there was a lot of what we call snake insurance. And this was insurance that only covered catastrophic events. So no prenatal care, no, preventative services, but if you were in a car accident or something very catastrophic. And there are many insurance out there who billed themselves as more than that and didn't cover anything. So when at first Obama came out and did the Affordable Care Act, he said, you keep your doctor, you pick your insurance. And one of the arguments against the Affordable Care Act was it made it so there couldn't be snake insurance out there. It made it so only high quality insurance could be out there. And because of that, some of these insurances, some people had to lose the insurance they had already had and re-sign up with another insurance, because it kept insurances out there that didn't meet the criteria from the federal government from still being in practice. So some people felt like they lost their insurance with this act and were upset. The ultimate goal, though, was to help people have insurance that actually had good coverage. And then let's talk a little bit about one group that was not served by the ACA, and this was undocumented people. With them, they did not, if you're undocumented in the United States, you do not meet requirements for Medicaid, and you also do not meet requirements for the Medicaid expansion, and you cannot get health insurance on the exchange. What you can qualify for is emergency services. Working in an obstetric ER, what I see happen is women can access emergency Medicaid who are undocumented for deliveries, but cannot access prenatal care. So this results in this group having worse health outcomes, because oftentimes they will come into the emergency room or the ER with things that could have been prevented with regular prenatal care. So they have higher risk pregnancies and worse outcomes due to the fact that they are not able to actually access prenatal care, but can only access emergency care. So, and I think many ERs run into this problem where they are, I will joke around and be like, well, we're their doctor, but the reality is they are running into patients who can access emergency care due to the fact that that's one element, but they can't access going to a regular doctor. So you might see people going to the ER for things that probably could be seen in urgent care and office, like ear infection, even getting growth ultrasounds. I've had patients come in who are 20 weeks. They're smart. They know when they should have growth ultrasound. They know when they should have a glucose test. And they'll usually come into the ER during those weeks and come in for care. So ultimately, I help as a provider. When I think of one way as an advanced practice nurse practitioner that I can improve equity with this group would be to have programs that improve access to healthcare for prenatal care, so that if you're undocumented, that you are not just receiving emergency care, but that you are seeing a doctor and have someone to go to get care for, and getting those prenatal care and that good guidance along with your pregnancy to help decrease adverse pregnancy outcomes. How do we as APRNs provide high-quality, evidence-based care to communities that are socially, economically disadvantaged? The American Nurse Association addresses this in the Code of Ethics for Nurses with interpretive statements. Central to this concept is the idea of providing fair and equitable access to high-quality health and high-quality healthcare services. This access is currently not available to all Americans, which brings the debate over whether healthcare is a right or a privilege. Dr. Martin Luther King Jr. addressed this injustice in healthcare by saying, "Of all the forms of inequality, injustice in health is the most shocking and inhumane. I believe APRNs can not only provide high-quality care, but also participate in changing and improving the systems that this care occurs. These changes can be performed on any level, from institutional changes to changing laws to improve access to care." As we're reviewing this chapter, I want you to think about what ways in your own communities that you can help become within your own sphere of influence, that you can be an access for change. Can you help with your clinic providing more services to more patients? Are you able to lobby within your own legislative bodies or your APRN or RN representative bodies in your state to help communities that have lower access care reach access? I would like to share with you in Utah one of the ways that we are better serving a population. In Utah, we are also having the opioid epidemic that many of you are having. And we started facing a problem as many pregnant women were coming into the ER. And these women were, not only were we having women who are on street drugs that are more recognizable, like spice and heroin and fentanyl, but we were also having women who were on chronic pain medications for pelvic inflammatory disease. So you'd have a patient coming in who had been on Percocet for 10 years, and they also had a medication dependence. So what ended up happening in our community was one of our doctors decided to open up a clinic that answered this population's need, and we call it Super Rad. But basically, this is a clinic that offers replacement therapies for women during pregnancy and specializes in caring for women who have substance abuse, giving them the services they need, such as social work, addiction recovery, methadone and Suboxone replacement therapies. And as an ER, we will support this clinic by doing emergency doses for methadone and Suboxone. Prior to this clinic opening, we had women who weren't receiving prenatal care because there were not providers within our community who were willing to take women who had substance abuse issues during pregnancy. Once this clinic opened, what I saw as a healthcare provider, it's been in operation for maybe 5 years. What I've seen as a healthcare provider is that women who typically did not get prenatal care, who just showed up to have a baby because they were using drugs, are starting to come to the hospital and being admitted for withdrawal management, getting off their drugs, going to replacement therapies, or if they're not able to get off the drugs, at least at the very minimum, they are receiving prenatal care, receiving services, social work help, and oftentimes adoption help. What I am seeing, or if they're choosing to parent, they're also getting classes and help with parenting. What I am seeing is better access to care. And this started by one provider. It was a nurse practitioner and a doctor recognizing a need in our community and opening a clinic. So that's what I'm hoping you can do. You can recognize the needs in your community and become those answers. We are going to review Linger's Sunrise Model. This is a conceptual model of nursing to depict components of the cultural care, diversity, and universality theory of nursing. It is named from the form of its graphic appearance. Each culture has a worldview and cultural and social structure, which are learned through language and environmental contexts. All of these language and environmental contexts influence the care and health patterns and expressions of individuals, families, groups, and institutions. All of the latter participate in diverse healthcare systems. To provide culture congruent care, nurses use knowledge gained through analysis of the components of the model to make nursing care decisions based on cultural care, preservation, maintenance, cultural care, accommodation and negotiation, or cultural care repatterning and restructuring. The culture care theory incorporates three major approaches to the delivery of culturally congruent nursing assessment. This is decision-making and interventions. Linger defines these modalities as the following. 1. Cultural care and preservation and maintenance. These are professional actions and decisions that help people of a particular culture to retain and preserve relevant care values, to maintain their well-being, recover from illness, or face handicaps and or death. Second, cultural care, accommodation, and negotiation. This is creative professional actions and decisions that help people of a designated culture to adapt to or to negotiate with others for a beneficial or satisfying health outcome with professional care providers. And third is cultural care repatterning or restructuring. This is professional actions and decisions that help a client reorder, change, or greatly modify their life ways for new, different, and beneficial healthcare patterns, while respecting the client's cultural values and beliefs and still providing a beneficial or healthier way of life than before the changes were co-established with the client. So I'd like to review a couple real-life examples when I think about these. So for the first one, I want to talk about a story from my brother-in-law. He's Native American, and his brother was going through addiction and recovery. And one of the way his medical team provided cultural care and preservation and maintenance is while he still attended group therapies and did Alcoholics Anonymous and some of those same cultural, some of those things, that those tools that can help him recover. He also saw his shaman from his tribe. And it was actually his medical professionals who asked him to go see his medicine man. And I think this was a great element of involving his, it was a professional action that basically helped him retain his culture and preserve his care values to maintain his well-being. So if you think about somebody who has a belief in a shaman or medicine man, receiving a blessing from that person would have a great help to their outcome and well-being as they are working towards recovery. And this is a good example of a healthcare team recognizing a cultural element and utilizing it for a good outcome. The second one involves accommodation and negotiation, right? So this is one of those experiences where a creative professional is able to work within a designated culture, but adapt and negotiate for the overall improvement of an outcome. When I think about this, there's a lot of different things that comes to mind when I'm working in the ER. But when I think about it, especially, we had a patient who had ruptured her water, and typically we try to deliver patients within 24 hours. She was from Africa, and in her country she had ruptured her waters with every baby and delivered a week and a half later. So this became kind of a difficult situation because within our medicine, in our culture, we worry about infection. But within her experiences, she had done this with 4 other births, and she had always ruptured 5 days prior to the baby, and no big deal. So one of the ways that there was an accommodation or negotiation was we talked with this patient about having her come every day for an NST. And an NST is just a way to see how well the baby is doing. So she would come into the hospital every day. We'd check her temperature. We would do labs. We would do a fetal well-being tracing, make sure baby was okay, and she would go home. The compromise is, in her world, she should just come when contractions start, but in our world, she should have been delivered. And the compromise was that she was able to let us do surveillance of her baby. And then the ultimate outcome was she didn't have infection. She did deliver 5 days post her waters breaking, just how she had with all of her other deliveries in Africa. So for me, it was a really good example of listening to this patient and incorporating her care into our care. Now, the third one, the cultural care repatterning and restructuring, I think for a professional, this is the hardest one. This is where you help a client reorder, change, or greatly modify their life ways for new, different, and beneficial healthcare patterns while respecting the client's cultural values and beliefs and still providing a beneficial or healthier life way than before the changes were co-established with the client. So if you think about the first one, going through all three differences. The first one, we are just preserving their beliefs. The second one, we're making accommodation or negotiation. So we're coming midway between their beliefs and our beliefs. Now the third one, we are asking for a major restructuring. An example I would go for is a patient I had who believed in massage therapy for cancer, and the patient had liver cancer. And this was a very difficult situation because they did not believe in cancer therapies, but did believe. So back to this patient, basically they believed that therapy and lemon essential oils would cure their cancer and did not want to receive services at our local cancer hospital, which in Utah is the Huntsman Cancer Institute. Ultimately, this patient's status declined, and as they declined and became more sick, there was a change of heart and what I would call a major repatterning as they accepted chemotherapy and radiation, and were able to actually receive services that would help improve their quality of life and also help them have a longer life. So these three values that underline these modalities are respect, advocacy, and partnership. A culturally competent advanced practice nurse is knowledgeable and respectful of diverse cultural beliefs and practices. When all these modalities in care are applied, the advanced practice nurse is doing culturally congruent care. Culturally congruent care is providing high quality care that is congruent with the patient's cultural beliefs and life ways. Sometimes this might involve you looking up their culture to get a better understanding, and sometimes this has involved me just with the patient saying, help me understand what this means too. I find many patients are able to help you understand more of their culture, and if you have an open mind, you'll be able to give more congruent care as you include their cultural beliefs in your plan of care. All right, let's do another quick knowledge check. Which pioneer developed the cultural care theory and the sunrise model? Was it Dorothea Orem, Claire Barton, Florence Nightingale, or Madeline Linginger? All right, it was Madeline. She developed the cultural care theory and the sunrise model. Her pioneering work in transcultural nursing and the development of her cultural care theory provides a framework for the practice of advanced practice nurses who care for culturally diverse populations. So let's talk about the National Center for Cultural Competence. Their mission is to increase the capacity of healthcare and mental health care programs to design, implement, and evaluate culturally and linguistically competent services and delivery systems to address the growing diversity, persistent disparities, and to promote health and mental health equity. Cultural competence is a developmental process that evolves over an extended period. Both individuals and organizations are at various levels of awareness, knowledge, and skills along with cultural competence continuum. Linguistic competence is the capacity of an organization and its personnel to communicate effectively and convey information in a manner that is easily understood by diverse audiences, including persons of limited English proficiency, those who have low literacy skills or are not literate, individuals with disabilities, and those who are deaf or hard of hearing. An organization can assess for cultural and linguistic competence by conducting a cultural competence self-assessment. This tool outlines a 5-step process in which, over a period of 3 to 6 weeks, using interview and questionnaire format for individuals and groups. Also, this questionnaire should be done for multiple people within the organization. So if you think about it, in my hospital, it would be done by the pastor, the nurses, the medical assistants, the social worker, and the patient. To best identify areas that need to change, you need to have multiple perspectives. This assessment can be found online through Georgetown University National Center for Cultural Competence. Federal agencies issue regulations affecting healthcare and healthcare providers. There are personal legal implications for failing to practice in a cultural and linguistically appropriate manner. In the Civil Rights Act of 1964, this outlaws discrimination based on race, color, religion, sex, or national origin. Title VI of the 14th Amendment is the non-discrimination in federally assisted programs. This prevents discrimination by programs and activities that receive federal funds. If a recipient of federal funds is found in violation of Title VI, they may lose federal funding. Healthcare institutions receive federal assistance, and if their programs or policies discriminate against particular cultural groups, they are liable to be held accountable under those provisions. Executive Order 13166 was issued. It states as follows: improving access to services for persons with limited English proficiency. That is the goal behind the order. This executive order requires that all individuals who do not speak English as their primary language and who have limited ability to read, write, or understand English may be eligible to receive language assistance with respect to a particular type of service, benefit, or encounter. In 2000, the OMH released the National Standards for culturally and linguistically appropriate services, and this is the CLAS, in healthcare and healthcare. These standards were developed to help healthcare organizations develop services that would promote culturally competent care with the goal of ultimately eliminating disparities and promoting better health. In 2014, the Joint Commission of Hospital Accreditation Standards adopted the enhanced CLAS standards in their accreditation. The Joint Commission also took the lead of addressing the healthcare needs of lesbian, gay, bisexual, and transgender persons receiving access to quality healthcare services. All right, let's do another quick assessment. Which agency has taken the lead in addressing the health needs of lesbian, gay, bisexual, and transgender I think this is a little outdated. I think it's LGBTQ now, but LBGT persons? The Joint Commission, Office of Civil Rights, Office of Minority Health, or the Center for Medicaid and Medicaid Services. So this was the Joint Commission. The Joint Commission has taken the lead in addressing the healthcare needs for LGBT persons, a population that has long experienced discrimination not only in health and access to quality healthcare services, but in many other aspects in their lives as well. As a provider, I have thought of some of the ways that I can help when I think about how do I make my clinic more inviting to this group of people so that they have better access to healthcare, that they're not coming to office due to discrimination. And some of the ways that I've worked on doing this is having in our offices pictures that show many different types of relationships, such as not just being a majority of heterosexual relationships, but also showing same-sex relationships and multiple races and ethnicities. At the hospital, one of my things I do is I have a little sticky note on the Epic. Everybody has different electronic records, but there should be a way that you can make notes that aren't included in the chart. But a way to remind you, I usually put down the pronouns that somebody goes by so that I am respectful in how they want to be addressed. And then lastly, when it comes to giving them good health care, trying to stay up to date. For example, one of my jobs as a women's health nurse practitioner is also managing birth control. And the highest rates of unplanned pregnancy for patients on birth control has typically been transgender males. And this is just because during that transition, if they're not perfect on taking the testosterone, they will actually still ovulate. So one of the ways that I'm trying to give better care to this group is informing them on birth control choices, which is typically Paragard because it's non-hormonal, and making sure they understand their risks to not have them at an increased risk for unplanned pregnancies while they are transitioning to a transgender male. The National Action Plan to Improve Health Literacy seeks to engage organizations, professionals, policymakers, communities, individuals, and families in an effort to improve health literacy. The action plan is based on two core principles. All people have the right to health information that helps them make informed decisions. Health services should be delivered in ways that are easy to understand and that improve health, longevity, and quality of life. There are several literacy assessments available. If you look in our text, Table 19.2 is a non-exhaustive list of these tools that you can utilize to evaluate the literacy or the health literacy that your clinic or practice is offering. Literacy in healthcare has moved from translation to transcreation. Transcreation is the process of changing a message from one language to another without changing the style, tone, context, or intention. Think of language, culture, and emotion all created for any content, any kind of content. Transcreation recreates the content and makes it applicable for a particular culture of people. Translation, in contrast, is new words in another language with the same messaging. It does not make the message applicable to the culture of another people. Patient navigator programs empower patients through the development of transcreated educational materials that are experiencing significantly difficult times in navigating the healthcare system. The goal of these programs are to link patients and families to primary care services, specialty care, and community-based health services and social services to provide more holistic patient-centered care and to identify and resolve patient barriers. So when I think about this, in the past, most of my health informations were just, translation. So you take one culture and translate it directly into another. Basically, it was translating the words, but not the culture. Transcreation is the ability to take the thought, but apply it to another person's culture, and to take elements of their culture in the message. And this is going to touch people deeply if you're using their own culture and their own beliefs in your messaging, right? You're going to create better buy-in. And when you think about the goal of the Navigator programs, this is trying to use transcreated education materials. So basically, it's trying to use cultural elements and help patients navigate our healthcare system. So when you think about this, it's basically going to be more successful because it's using elements of their beliefs to promote positive healthcare behaviors and then also helping them better access care. And navigating our healthcare system can be difficult, so I actually think this is a very necessary step when we talk about increasing access to care, is teaching people how to access that care. I talked earlier on about what happened when I saw the Affordable Care Act. Like when this came to place, all these patients, oftentimes they would come to me with everything because they didn't understand that there were several specialists. So chief complaints would be, I have migraine headaches, I have a breast lump, I haven't had a period for 2 years, my blood pressure's high, and I have headaches. And so part of my job as their provider was helping them understand how to navigate. And these programs can do that while still using someone's cultural background, which is going to be strong whenever you use someone's self-belief models in behavior change. Assessing cultural competence starts within ourselves. Each of us brings the influence of our own cultural heritage, experiences, biases, beliefs, and expectations about patient-provider relationships and the care we give. Evaluating these influences on our caregiving practices is the first step to achieving cultural competence and congruence as a provider. Georgetown University Center for Child and Human Development offers an array of tools for assessing cultural competence in individuals and organizations. An excellent self-assessment tool is the 37-item checklist promoting cultural and linguistic competency. You can find this tool by visiting the NCC website at http://nccc.georgetown.edu. This is a clinic on self-assessment. So you can use this tool by Georgetown for either an individual provider or actually your clinic of practice or your organization. In 2016, the Cultural and Linguistic Competence Health Practitioner Assessment was made available on the NCCC website. This tool can improve our ability as advanced practice nurses to provide culturally and linguistically competent care to meet the health and mental health needs of our patients. The defining characteristic of advanced practice nurses across multiple settings is the ability to partner with patients to provide care that the patient perceives as being respectful and inclusive of his or her uniqueness. The challenge starts with practicing in a way that is sensitive to our own biases and cultural backgrounds. We need to recognize our culture and how that affects our perspective and see our patient's culture and try to bridge the ground between the two of them, respecting them and seeing. Basically, I find this is recognizing what color of lens we are looking through and seeing this situation through those lenses. All right, thank you so much. Please, for this section, I would want you to go onto that website and take some time to take a good self-inventory and look at what areas you think you can work on. We all have areas to work on, and as we make that work, we will become better providers. Thanks so much for your time.